Vanakkam, Namaste, good evening. During the course of the next 1 hour, I'll try to give you an overview on human male reproduction. During the course of this 1 hour, I'll try to give you the details about anatomy and function of the male reproductive system, spermatogenesis, and the diagnosis of male infertility. Before we understand the anatomy and function of the male reproductive system, it is important that we understand how is sex determined, how do the gonads develop, how does the development of the male genitalia happen, what is the anatomy of the male reproductive system, what is the endocrinology and physiology of the male reproductive system, and how all these things coordinate to make man have normal male reproductive function. Remember, sex is determined at conception. At the moment of conception, the spermatozoa enter the oocyte. The genetic sex is determined. The spermatozoa entering the oocyte determines the sex of the fetus, the embryo, and the future child. X or Y chromosome bearing spermatozoa determines the genetic sex of the embryo, the fetus, and the child. It is not clear at this point in time if this is a random event or either the spermatozoa or the oocyte or anything else has a role in determining which spermatozoa enters the oocyte. After this event, the next important event is gonadal differentiation. SRY, sex determining region of Y, short arm of the Y chromosome, carries this region. This elaborates testis determining factor. That's the primary genetic signal determining the direction of the gonadal differentiation in mammals. SRY activates a number of other genes like SOX9 that promote testis development. The sex determining region of the Y chromosome, the short arm, initiates molecular events leading to the formation of testis. Absence of Y chromosome leads to the formation of ovaries. But absence alone is not enough. Both X chromosomes are essential for normal ovary development and function. The absence of one X chromosome and the presence of only one X chromosome leads to the condition called Turner syndrome. As all of you know, the gonocytes are formed in the ventral wall of the yolk sac. They travel by amoeboid movement and reach the gonadal ridge. As they travel, they also proliferate as they keep migrating. They reach the gonadal ridge by 6th to 7th week. It's not clear what guides and initiates the migration of the gonocytes or the primordial germ cells to the gonadal ridge. Is it chemotaxis? That's a point for discussion. Development of gonads before 7th week, both XX and XY fetuses have identical reproductive anatomy. At 7 weeks, by the direction of the chromosomes, either the testis or ovaries form. Fetuses with Y chromosome form the testis. Fetuses with both X chromosomes form normal ovaries. Both X chromosomes are essential for development of normal ovaries. This gives you an outline about what really happens. Around 4 to 6 weeks, the primordial germ cells migrate to the gonadal ridge to form the bipotential gonads. At 6 to 7 weeks, the Sertoli cells form. They play a crucial role both in spermatogenesis and in the development of genitalia. The Sertoli cells secrete a substance called anti-Mullerian hormone. This leads to a regression of the Mullerian tract. Leydig cells form and they start secreting testosterone. Fetal testosterone is essential for the development of the rest of the male genitalia and for the development of the external genitalia. At around 10 weeks, Mullerian ducts meet, Wolffian ducts degenerate if in case there's no Y chromosome. The presence of testosterone leads to the development of internal genitalia under paracrine testosterone influence. This happens around 9 to 12 weeks. By 9 to 14 weeks, under the influence of dihydrotestosterone, this is produced by the conversion of testosterone by 5-alpha reductase. Dihydrotestosterone leads to the development of external genitalia, the penis, the scrotum, prostate. By 16 weeks, if this does not happen, by 16 weeks, uterus and vaginal development is complete. 20 weeks, female external genitalia develops. Wolffian ducts that forms the male organ develop first, differentiates into the epididymis, vas deferens, and seminal vesicles in men. Wolffian duct regresses in female. Mullerian duct develops later. This differentiates into the fallopian tubes, uterus, and upper portion of the vagina in females. Regresses in men under the influence of anti-Mullerian hormone. High local concentration of testosterone stimulate the ipsilateral Wolffian duct to differentiate into the epididymis, vas deferens, and seminal vesicle. Duct system differentiates according to the nature of the adjacent gonad. The Wolffian ducts do not form. Mullerian duct development also fails. Abnormalities in the renal system are highly associated with abnormalities in the development of the fallopian tubes, uterus, and upper vagina. This gives you an idea about development of the external genitalia. I emphasize because you may have to handle patients. In the sense your clinician may handle it, but you have to give them the confidence and courage, because there are men born with a difficult open system where you don't find the testis lying outside. It could be an undescended testis, or it could be a genitalia which is ambiguous. If they are men, you will still be able to recover sperm from some of these men from the testis. The fetal lady cells secrete testosterone at 8 to 9 weeks gestation. Masculinization of the external genitalia begins 1 week later at approximately 10 weeks. Genital tubercles forms the penis. Urogenital sinus fuse to form the penile urethra. Labioscrotal folds fuse to form the scrotum. This process is complete by 14 weeks. Again, as I mentioned before, there are some men who report with ambiguous genitalia. External genitalia share a common origin in both sexes. Ambiguous genitalia results from abnormalities in androgen action. Remember, if there are too much androgen, a female fetus will have an ambiguous genitalia. If it's too little androgen, a male fetus will have an ambiguous genitalia. Basically, it's androgen action. Prenatal androgen exposure affects brain and the behavior as too. And sex chromosomal problems also can lead to ambiguous genitalia. If there is one extra X in a man, instead of 46XY, he has 47XXY. He's got a condition called Klinefelter syndrome. Previously, these men were hopelessly infertile. Today, with sperm retrieval from the testis, we can recover sperm from these men by sperm retrieval from the testis, or what we call as TESI, testicular sperm extraction. Super female can have problems, or they may be normal. Turner syndrome, again, there is one X or Y chromosome missing. If a patient is 45XO, you find these women have problems. They have a dysgenetic ovary, and they may be amenorrheic, or if they are occasionally menstruating, they may have early menopause too. These women may require oocyte donation. Basically, the problem with abnormal sexual development is androgen, either excess in women or too little in men contributes to this problem. And this also can have an influence on the development of the brain and the behavior. That summarizes the development of the male genitalia. It gives you an idea about how the male genitalia develops. Yeah. Now just a word about the anatomy. All of you are familiar with this. The testis is, there are two testes enclosed in the scrotal sacs, and on top of that is the epididymis. The word epididymis means upon. Didymis is testis, upon the testis is epididymis. So they are, epididymis is a long tortuous tube, about 20 feet long, tucked into a small area. Then epididymis ends as a vas deferens. The vas deferens is a circuitous route, and it reaches in out of the pelvis and joins the seminal vesicle. They both open by a common ejaculatory duct into the prostatic urethra. And all of the secretions come out through the urethra. This is a very brief description of the anatomy of the male development tract, male genital tract. This is a further description. You look at the testis, you find there's an external layer called tunica albuginea, which is thick and unyielding. and beneath which is the tunica vasculosa. Beyond that is the tunica vaginalis, and it has got, each testis has got about 250 tubules and a lot of spermatogenesis going on in them, and all these open into the rete testis, which are again producing efferent ductules. They all unite to form a single tubule called epididymis. The whole of epididymis is a single tubule tightly coiled upon itself to form a one tube into, and it ends in the vas deferens. Vas deferens is an initial coiled portion. Later on, it becomes a straight tube. And as mentioned before, it has a longer circuitous route and joins the duct of the seminal vesicle, becomes an ejaculated duct, and opens into the prostatic urethra. Seminal vesicles play a very crucial role. Though they are not organs of reproduction, they contribute to the seminal volume. And seminal volume helps in transporting the spermatozoa. 70% of the seminal volume is contributed by the seminal vesicle. They also contribute fructose. So this is a very important marker. When you're doing a semen test, you always look for fructose. And absence of fructose gives you a clear pointer about absence of seminal vesicle or seminal vesicle dysfunction. Remember, sexual reproduction, asexual reproduction is a predominant form of reproduction in prokaryotic life forms. Cells reproduce by binary fission, budding, vegetative propagation. But later on, because reproduction is a law of life. Life begins life. All life has some common feature. All life which reproduce, survive and thrive. All cells are programmed to reproduce or aid in reproduction. Gametogenesis is a very peculiar phenomenon for the mammalian. Mammalian reproduction requires gametogenesis. Gametogenesis is the process by which diploid primordial germ cells undergo cell division and differentiation to form mature haploid gametes. Gametogenesis is the process of gamete formation. This happens in the gonads, and it can happen only in the gonads. If you transfer the gonocytes elsewhere, they do not divide and grow and form the mature gametes. The male gamete, as you all know, is spermatozoa. The singular, spermatozoa is plural. The primordial germ cell is spermatogonia in the man and oogonia in the woman. There are two types, type A and type B. Head is, to learn a word about the structure of the spermatozoa, which you will know more later. The head is 2, 3, 4 microns. 2 is the thickness, 3 is the width, and 4 is the length of the head. The tail is about 25 to 50 micron. That will give you about the physiology of spermatogenesis, or how exactly what happens. There are more than 200 genes involved in spermatogenesis, most of which are located in the autosomes. 30 genes are located in the long arm of the Y chromosome, and deletions in this area is what you are looking for when you're doing Y chromosome deletion studies. A deletion in the segment A, B, or C, the long arm, can lead to azoospermia or severe oligozoospermia. A and B often leads to azoospermia. C can lead to either azoospermia or severe oligozoospermia. Just a word about the physiology. As you can see from this slide, from the hypothalamus comes the GnRH. GnRH stimulates FSH and LH. GnRH stimulates FSH initially, which acts on the Sertoli cells. Sertoli cells produce transferrin and androgen binding protein. At the same time, LH acts on the Leydig cells. Leydig cells produce testosterone. This testosterone circulates the blood, and testosterone also is actively transported by the Sertoli cells into the intraluminal compartment. Sertoli cells transport testosterone by combining with an androgen binding protein. This transfer leads to an intraluminal concentration, 50 times the plasma concentration. This is not possible to mimic this by pharmacotherapy. If you attempt giving testosterone to a man, that leads to reversible suppression, can even lead to azoospermia. So the rate limiting factor is Sertoli cell. You need the Sertoli cells to support spermatogenesis, and the intraluminal concentration also needs to be high. Sertoli cell also secretes a substance called inhibin, which produces suppression of further FSH secretion. Remember, there is always a negative feedback in most hormonal secretions. Same way, Leydig cells secrete testosterone, and that leads to negative feedback and suppression of LH. So FSH and LH are under dual stimulation from GnRH to stimulate production, and feedback from the inhibin from Sertoli cells and testosterone from Leydig cells lead to suppression. This is the complex mechanism which initiates spermatogenesis and keeps it going. To repeat again, at the onset of puberty, what triggers puberty? Nobody is clear. Maybe weight gain, or it is genetically determined, or environmental factors. A lot of factors are involved. But basically, when puberty is triggered, GnRH pulse started happening. GnRH leads to the stimulation of FSH and LH secretion from the anterior pituitary. LH acts on the Leydig cell, leading to the production of testosterone. Testosterone is essential for normal secondary sexual character development. Testosterone is also essential for spermatogenesis. FSH, on the other hand, acts on the Sertoli cell, and Sertoli cells are the nursing cell or supporting cell for spermatogenesis. These cells also produce inhibin, which suppresses FSH for the secretion. Sertoli cells also produce transferrin, which supports the growing germ cells. This again to give you another view of it, to look at the molecular level. The FSH, LH, and testosterone circulate in the blood. FSH acts on the Sertoli cell, LH on the Leydig cell. The intravascular testosterone is transferred to the intraluminal compartment by Sertoli cells by a protein called antigen binding protein. This transfers to the lumen 50 times the plasma concentration. This cannot be mimicked by pharmacotherapy. If you give pharmacotherapy by testosterone, that will only lead to suppression of spermatogenesis. And the major rate limiting factor in spermatogenesis is the availability of Sertoli cells. Sertoli cells are crucial for the spermatogenesis. They are the cells which nurture, support, and form the blood-testis barrier. They are crucial, and these cells are limited in numbers. They do not grow in adult life. So you cannot increase the sperm count of a man beyond a certain point, because in adult life there is no further growth of Sertoli cells. The sperm count may vary from time to time, but beyond that you can't do anything much to improve the sperm count by pharmacotherapy, except in patients with hormonal deficiency. Well, as I mentioned before, what initiates puberty and gametogenesis, no one is sure. It's probably the maturation of the higher cortical centers, maybe body weight, maybe the hypothalamus and pituitary. Look at patients with precocious puberty. We do not know what triggers. There's a condition called idiopathic precocious puberty. We have no reason at all what's triggered it. Several hormones are involved in the initiation of puberty, like GnRH, FSH, LH, leptin, growth hormone, and thyroxine. Well, you all know the spermatozoa have two varieties, the 22 plus X or 22 plus Y. Whereas you have only one type of oocyte, it's all 22 plus X. Can we separate the X and Y bearing spermatozoa? As clinical results, this may be of interest to you. To a limited extent, yes, you can separate, but you don't get a 100% sperm rich X or Y rich portion. So that is why these techniques have not really become very popular. You may still fail, you may have only 70% Y sperm and 30% X sperm, which will produce a pregnancy, nobody's sure. So sperm separation techniques have not been useful in producing children of the desired sex. And again, to reiterate, spermatozoa determines the sex of the offspring. The primordial germ cell, as all of you know, is spermatogonia. It's type A, pale and dark, of stem cells. Type B spermatogonia undergoes spermatogenesis. Type B spermatogonia gives rise to 4 spermatids and spermatozoa, unlike in the woman, where one oogonia produces only one oocyte. In the man, type B spermatogonia leads to the production of 4 spermatids and 4 spermatozoa. And remember, spermatogenesis occurs continuously from spermarchy. That's a word we coined, which means the onset of production of spermatozoa. Again, nobody knows for sure when it happens. It happens at some time during puberty. But this sperm production goes on till death. A man never stops producing sperm. There is no spermopause or male menopause. There's only an androgen deficiency of the aging male and there's no andropause. Production of spermatozoa starts from puberty. It happens inside the seminiferous tubule of the testis. One cycle takes 64 to 72 days, and man produces about 300 million spermatozoa per day. As mentioned just now, men do not undergo menopause or spermopause. They may undergo androgen deficiency of the aging male, what we call as ADAM. Spermatogenesis occurs 24 hours a day, 7 days a week, with non-stop. And we could recover sperm. This is again something which you may face as time passes by as clinical embryologists. Mortal spermatozoa have been recovered from the testes from men who are dead. I'm not talking of patients who are kept on life support, not patients who are on ventilator. People who have been declared dead, even from those men, so far, people have recovered sperm and produced a pregnancy until 48 hours after death. Well, this is again a situation where patients have got no testis in the scrotum, what we call as undescended testis. We really do not know. There is a lot of explanation why testes are in the scrotum. The conventional explanation is they require lower temperature for spermatogenesis. But if you look at other mammals, this is not true. There are a lot of mammals which have the testis inside the abdomen. Elephant is one, and they're able to produce. So we do not know why the human testis is outside. But nevertheless, when the testis is not outside, it can be a problem in sperm production. We often think that undescended testis is defective and therefore it fails to descend. So these testes are impaired sperm production. There may be no spermatozoa at all, but sometimes you can recover sperm from the undescended testis by sperm retrieval from the testes, or what we call as testicular sperm extraction. By this technique, you can recover sperm even from undescended testis and attempt pregnancy with ICSI. The effect of undescended testis is impaired spermatozoa production and azoospermia when bilateral. There is also a risk of malignancy and the inability to diagnose early. If you leave an undescended testis inside the abdomen or in the inguinal canal, you may miss picking up an early onset of malignancy. Therefore, it is important either you fix it in the scrotum or remove it and not leave it to remain undescended. That pictorially represents spermatogenesis. You can see the Sertoli cells with an irregular nuclei, how they closely support the growing germ cells from spermatogonium to spermatocyte to secondary spermatocyte, spermatid, and spermatozoa. The process of spermatogenesis is again described in this picture also. Spermarchy is an undefined event. Remember, the process goes uninterrupted till death. An adult man produces 1,000 spermatozoa per second. This again shows another step in spermatogenesis. You find a round spermatid. It gradually changes to become the elongated, mature spermatozoa. This process is called spermiogenesis. This again happens in the testis with the support of the Sertoli cells. Normally, these spermatozoa are released only after they become mature, but sometimes you can see immature germ cells also in the ejaculate. There are too many immature germ cells in the ejaculate. It indicates there's some problem with spermatogenesis. So basically, spermatogenesis involves three processes: a spermatogonial phase or spermatocytogenesis, which is mitosis; a spermatocyte phase from primary spermatocyte to secondary spermatocyte, which is a reduction division called meiosis; the spermatid phase, where spermiohistiogenesis or spermiogenesis. Spermatogonia represent reserve sperm cells. Stem cells, a pale spermatogonia represents active stem cells. And this is the correct process: a dark one, pale one, then pale spermatogonium, then type B spermatogonium, and then you have the process of spermatogenesis going on with the occurrence of primary spermatocyte, secondary spermatocyte, spermatid, and a mature spermatozoa. This gives you an idea about how the spermatozoa looks, which you're all familiar. The important point is that sperm tail has this configuration of what is called as 9+2. This is important. Sperm tail is crucial for sperm movement. The sperm movement is affected. It probably indicates a problem in the sperm tail. I want to reiterate again, Sertoli cells are crucial. You have the supporting cells, nursing cells, and they're also called as they sustain. They're called sustentacular cells. They support, nurse, nourish, and sustain the growing germ cells. They also form the blood-testis barrier. They are forming a barrier. The nutrients and other substances reach the germ cells only through Sertoli cells. They produce antigen-binding protein, inhibin, transferrin, besides many other products. Antigen-binding protein selectively transfers testosterone to the intraluminal compartment to re-emphasize a very high concentration of testosterone in the intraluminal semivestibular compartment is important for spermatogenesis. Now you have a background about the development of the genital tract, the physiology of spermatogenesis, and the process. Now let's move on to see what is infertility. Infertility is a disease of the reproductive system defined by the failure to achieve a clinical pregnancy for 12 months or more of regular unprotected sexual intercourse. It is now widely accepted infertility is a disease. It can also be a symptom of underlying disease. Thus, the data again, it clearly indicates that the large majority of men, there is no demonstrable cause. Varicocele is a questionable cause. In majority of the nation, you don't find any cause at all. They are otherwise healthy men with only abnormal semen parameters reporting to you. Remember, I want to reiterate the anatomy again. Each test is a spheroidal shape located in the scrotum. The coverings are important because there's a bearing on the clinical picture. The coverings are from outside: tunica vaginalis, tunica albuginea, tunica vascularis. Tunica albuginea forms septa separating the testes. Each testis contains 250 lobules. And remember, this tunica albuginea is thick and unyielding. Therefore, any trauma to the testis or any inflammation of the testis leads to swelling, but it cannot expand outside. Therefore, it puts pressure on the content of the testis, leading to atrophy and avascularity and degeneration of the seminiferous tubules. These are some facts and figures about each testis. I mean, this varies from book to book, not hugely. Minor variations are always there. Remember, these are facts you have to remember and memorize it. As I mentioned before, epididymis, these are all direct bearing, because in clinical embryology, you're going to handle epididymal fluid, testicular extraction, testicular tissue. So remember, it's a single tubule, tightly coiled upon itself. It's about 6 meters or 20 feet long. It is primarily believed that it's got a storage function. It's not clear whether human being also store spermatozoa in the epididymis. People believe from animal work that spermatozoa are stored in the cauda epididymis because of the low temperature. This is not, again, very sure in human being. We have recovered sperm from all points. In men with obstruction, you can recover sperm from any point in the epididymis. But the best spermatozoa are obtained from the caput, not the corpus or the cauda. It takes about 2 days for the spermatozoa to travel in the epididymis. Vas deferens, as you saw before, it can be absent in some men in a condition called congenital bilateral absence of vas deferens or vasal aplasia. It's about 35 to 50 centimeters long. The ampullary end joins the seminal vesicle to form the ejaculatory duct. There are other accessory glands like seminal vesicle, prostate, and bulbourethral glands. The bulbourethral glands are also called as corpus glands. They secrete a fluid to lubricate the urethra. Remember, urethra in man carries the urine and also the ejaculate. So before a man ejaculates, the urethra is lubricated by the bulbourethral glands, and the passage is made less acidic. Seminal vesicle contributes to the major volume of semen, up to 70%. Prostate gland contributes about 25%. Testis only contributes to 5% of the semen volume. This is very important to understand. In patients who have vasectomy, the semen volume will not go down. In patients who have an obstruction at the epididymis, semen volume will not go down because testicular contribution to semen volume is only 5%. The seminal vesicle have a crucial role, as I told you before. One of the markers is fructose. Besides, it produces a lot of other substances. It also produces seminogenin, which is important for forming the coagulum. As all of you know, at collection, soon after collection, semen forms a coagulum and gradually liquefies. This is important to keep the semen in the vagina And this is coagulation is crucial. The major marker for spermatogenesis diagnosis is fructose. Though there are other substances, they are not really markers. The major marker for the presence of seminal vesicle is fructose. This again gives you the histology of spermatogenesis. Remember the tight junction. This is important. You know the Sertoli cells form tight junction. These tight junctions prevent passage of proteins from interstitial space to the lumen. This blood-testis barrier is supposed to be as strong as blood-brain barrier because nature wants to protect both the brain and the future offsprings, and therefore this is a fairly tight barrier. Nevertheless, we try to break this also by taking all kinds of chemicals and junk food. The importance is to protect germ cells and spermatozoa from being exposed to immune cells and other toxic materials. The Sertoli cells also transport nutrients to the developing germ cells, and they will transport antigen by using the antigen binding protein. Leydig cells, as I mentioned before, secrete testosterone and aid in spermatogenesis. Both FSH and LH are essential, and intraluminal high concentrated testosterone is essential for sperm production. Well, when do you diagnose a man as infertile? A man would be infertile if he has lack or loss of libido and does not perform the sexual act. That's very obvious. If he has problems in erection, he has got erectile dysfunction and is unable to perform the sexual act. If he is able to perform the sexual act but is unable to ejaculate. There are men who have problems with ejaculation. They have ejaculatory failure, or they have retrograde ejaculation, which means they ejaculate instead of coming forward and go back into the bladder. So these conditions can also produce male infertility. Or he's having a good erection, good ejaculation, but the ejaculate is inadequate by the current standards, which means the ejaculated semen may have no spermatozoa at all. That's really a case of infertility. In other situations, are all relatively subfertile. A man with low concentration is subfertile and not really infertile. Most male infertility diagnoses are just descriptive terms. Remember, there's no condition in a man called oligozoospermia. His semen picture shows oligozoospermia. There is no physical feature. A man could have normal features and still have oligozoospermia. A man could have normal features, normal testes, normal vas, and he still could have azoospermia because there's an obstruction at the epidermis, which cannot be picked up by physical findings alone. So many of the terms we use commonly are descriptive terms of the semen picture, and they do not have any clinical correlation. Some conditions do have clinical correlation. For example, a man with a low volume semen sample with no fructose in the semen, he may be having a condition called basal aplasia that you can diagnose both clinically and by semen analysis. That is why a proper semen analysis, estimation of fructose becomes crucial. A man with azoospermia, low volume semen, and no fructose may indicate either obstructive azoospermia due to basal aplasia or ejaculatory duct obstruction. And remember also, a man's fertility is influenced by his partner's fertility. You cannot call a man alone as fertile based on his seven parameters. A woman's fertility is influenced by her partner's fertility too. This slide will give you an idea about how they both interact. Let's assume they both contribute equally, 50-50. And you find if one is deficient, the other can lead to problems. So if man is normal, woman is normal, everything is fine. If one is abnormal, other is supernormal. For example, a young woman is optimally fertile. Even man has got a low concentration, it may still work out. On the other hand, if they both have problems, man has got a very low concentration, low motility. Woman has irregular cycles or she ovulates infrequently. They both are subfertile. They may come with infertility and report to you. A detailed history is important. Remember, in evaluation, in diagnosing male infertility, people often tend to think that semen analysis is good enough. No, it's not good enough. You need to have proper history. Even when you are doing a clinical embryology job, please ask the man, how did he collect the semen sample? It's important. A detailed history brings the significant factors affecting fertility of the individual. And a simple correction of these would restore fertility. Remember, gametes are specialized cells in the human body. They are affected by any disturbance in health status of the individual. They have significant impact of age and fertility. Yes, a man also becomes less fertile with advancing years. In fact, the fertility starts declining by 30s. But the marked decline happens only in 40s. And again, they can also have aneuploidy in the spermatozoa and contributing to aneuploidy in the embryo. And exposure, a lot of men are today exposed to chemicals, pesticides, and radiation. In fact, exposure to high heat, disturbed sleep, nutrition, all of them can contribute to altered semen quality. They will not produce azoospermia, but they do alter semen quality, and these men take longer to produce a baby. So it is important to understand that vertical compounds also can suppress gonadotrophin secretion. Again, people are now addicted to a lot of drugs, cigarette smoking, alcohol. All of them can lead to impaired sperm parameters. The alcohol, on the other hand, and cannabis and marijuana can produce impaired sexual desire and performance. It is also important to ask a sexual history. If sometimes you feel delicate, it's important. Never miss this point because a detailed sexual history gives you a clear clue. A simple example would be use of lubricants. Many couples start using lubricants early in their marital life because it's painful to start with. But they never forget to, they continue to use it and forget to stop using it. Lubricants are all right for sexual intercourse, but they're bad for the spermatozoa. All lubricants are either spermicidal or spermistatic. Therefore, if you are attempting pregnancy, please encourage a couple to stop using lubricant. The best lubricant would be adequate foreplay and vaginal secretions. Otherwise, there are other lubricants available commercially, which are a second choice. And again, history can give you an idea about non-consummation of marriage, infrequent sexual intercourse, or improper techniques. That is why history is very important. So also remember, duration of marriage is important. The longer the wait, more complicated things become. I often say infertility is a race against time. Two crucial factors, age of the couple and the duration of marriage, both are important, particularly age of the woman. Therefore, please ask a detailed history. And when you are doing clinical embryology also, look at what the age of the couple. And remember, people also have sexual dysfunction. And sexual dysfunction includes both erectile and ejaculatory dysfunction. Many men with normal sexual function start developing sexual dysfunction after the diagnosis of infertility. And the mere fact of asking to collect a semen sample in the hospital can lead to performance anxiety and sexual dysfunction. In fact, 25% of men develop sexual dysfunction when they are told they have azoospermia. So infertility is a very psychologically demanding situation. So please bear it in mind and be very sensitive about handling this situation. Besides this, history again is important when you find out these men are on drugs. I'm talking of pharmaceutical drugs, not the social drugs. These drugs can also produce problems, both in terms of erection, ejaculation, and in the quality of the spermatozoa. You see a huge list of drugs here. They all can lead to problems in fertilization failure, impairment of spermatogenesis. Again, conditions like carcinogenesis syndrome, where they have a bronchiectasis or cough and cold, that can lead to problems in the sperm structure or sperm movement. Many chronic diseases can lead to problems. So if you're looking at a man who's coughing and reporting to you the childhood problem, he may be having carcinogenesis syndrome. And history, again, as I may re-emphasize, ask specifically for history of torsion, history of undescended testis, history of smoking, all of which are torsion needs to be fixed adequately and pretty early. That can prevent infertility. Childhood history is important. Surgery, particularly in childhood, particularly inguinal surgeries. Inguinal surgeries have very high risk of the vas being involved. So ask for inguinal surgery, particularly hernia repair surgery. And some men have had vasectomy. They may not reveal the information when you're discussing with the wife. So history of vasectomy, varicocelectomy, hydrocelectomy, all may contribute to infertility. And surgery in the para-aortic region, any dissection in the retroperitoneal area may lead to problems in sexual function. It can lead to problems in the parasympathetic, sympathetic nervous system, and these men can have problems both in erection and ejaculation. As I mentioned before, history of mumps is crucial. A significant number of men have a history of mumps, and the mumps leads to orchitis. That's an autoimmune phenomenon, and this orchitis leads to testicular atrophy, and they may not even remember the story. You may have to ask them to go back and check with their parents. So childhood mumps can lead to problems of orchitis and testicular atrophy. So history becomes important. Mumps orchitis can lead to impairment of sperm parameters or even permanent damage to the testis. They may not present with peritonitis, or they often present with peritonitis. The mechanism by which orchitis influences infertility is the edema. The testis swells up, it can't swell beyond a certain point, leads to intratesticular pressure and impairment of spermatogenesis or atrophy of the tubule. Also ask for history in the family of anybody, close family members having had infertility. It's also important to understand the nutritional status. Obesity certainly impairs sperm parameters. We all know with adequate nutrients that medical illness like diabetes mellitus, hypertension, and the treatment for all may all lead to sexual dysfunction. When you examine the man, also please look for androgenization. Absence and infrequent shaving may all indicate of less androgen levels, and this can also mean in some men condition called Klinefelter syndrome. And there are other men who have not attained puberty at all. Many of these people don't come to the infertility clinic, but they may report to you if they have not been attended to earlier. Some of these men would have gone to the endocrinologist or a physician and had testosterone therapy. But if they have not had, they come with unicaudal features. And if they have unicaudal features with gynecomastia and soft small testes, you have to think of Klinefelter syndrome, and the karyotype will tell you it's 47XXY. If these men with Klinefelter syndrome have elevated levels of FSH, small and firm testes, gynecomastia, loss of libido, sparse facial and pubic hair, increase in the height, erectile dysfunction, is a clinical presentation. And we need to examine the man. In fact, this has been going on in journals. Do we really need to see the man? Is it not enough if we leave a semen sample? Is clinical andrology dead? Is surgical andrology dead? These are questions which are only academic interest. You're dealing with a human being, a human couple who come to you for having a child. So it's important you evaluate both the couples. And when you examine the man, the wife is reassured that she's not to be taken all the blame for. Examine the man both in the supine posture, lying down posture, and in the standing posture. Look at the urinary meatus, look for meatal strictures, look for evidence of phimosis, see if his meatal opening is in the correct point at the tip or not, on top or at the bottom. What conditions called epispadias and hypospadias. If these conditions exist, simple correction will ameliorate sexual dysfunction and infertility. Phimosis is a common cause of painful intercourse and it's very simple to correct it. And look at the scrotum to see if the testes are there. Absence of testes is a condition called cryptorchidism or undescended testes. Also examine to see the size of the testes. There you can use a prenatal orchidometer, use a clinical examination, or use a vernier caliper. All of them can give you an idea about what is the size of the testes. Then this shows the prenatal orchidometer. The normal size varies from anything from 8 to 15. Just as human beings are a huge range of height, and the testis also ranges from size. A very small test like 2 ml, 3 ml clearly indicates that there's a problem with the testis, either with the testis or with the hormone required to make the testis grow. The testis size primarily is from the seminiferous tubule. 80 to 90% of the seminal testis volume is contributed by seminiferous tubule. A small testis indicates, as I mentioned before, either the seminiferous tubule are atrophied or they have not been stimulated, as in hypogonadotrophic hypogonadism. The normal volume, to reiterate, is about 8 to 15 cc. It could be a little larger or a little smaller. We rarely see a testis which is normal, which is less than 6 cubic centimeters. A low volume indicates hypogonadism or seminiferous tubular failure. A high volume indicates hydrocele, emetocele, tumors, or filariasis. Also look for testicular sensation. A mindful, painful sensation to touch is normal. Most men are very sensitive to testicular sensation, so do not squeeze the testes. An exquisite tenderness indicates torsion or infection. An absent sensation indicates either a seminoma testis or leprosy. Epididymis is felt on the posterolateral aspect of the testis. When it's distended, it is not often you can make it out, but when it's distended, it indicates obstruction beyond the epididymis. And distended epididymis is suggestive of obstructive spermia, either at the cauda epididymis or it could be basal aplasia or elsewhere. The vas deferens feels like a cord in the neck of the scrotum. You can roll it between your fingers. You may not feel it in the patient with basal aplasia or congenital bilateral absence of vas deferens. A normal size testis, well androgynous male, vas not felt in the scrotum, usually is a condition called congenital bilateral absence of vas deferens. This is also called as basal aplasia. These men report with a semen picture which is very low volume semen, just 0.2, 0.3 ml, no spermatozoa, absent fructose. Varicocele is a questionable cause of male infertility. We were doing once upon a time varicocele surgeries. Now we believe with all the new technologies, with all of you people, clinical embryologists, to help the clinician, if there is sperm, attempt a pregnancy with whatever amount of sperm you have, rather than trying to improve it by any surgical measures. Oligoastenospermia cannot be improved by surgical measures. Of course, if you believe in varicocele, you need to confirm by doing the ultrasound. Rectal examination is rarely indicated. Primarily, if you suspect basal aplasia, you can do a rectal examination and confirm the absence of seminal vesicle. But you can equally confirm by doing a semen test, identifying the absence of fructose in the semen. The most important semen test is semen analysis. People tell you that semen analysis is not very reliable. It's true. It has got a poor positive predictive value and a poor negative predictive value. It's not a very sensitive, it's a very specific test, but not a sensitive test. A normal semen picture does not guarantee pregnancy. Nevertheless, it's the most important test for evaluating male infertility. So you need to know how to do a proper semen test. It has limitation, but all the tests which came to complement, have not done anything better. They cause more confusion than clarity. Basic male investigation remains detailed history and physical examination. Semen analysis is the first line laboratory test. We do hormone tests only if the semen test is abnormal or the man has got a sexual dysfunction. And a man who is able to perform sexually well, a normal semen picture does not require any hormonal evaluation. If, on the other hand, he has got azoospermia, you have to do an FSH, sometimes NLH, prolactin and testosterone to confirm he's got a central cause like hypogonadotrophic hypogonadism. That's the WHO reference value. You will see that you are all familiar with this. And based on the WHO semen values, we have a lot of definition of the male picture. Remember, aspermia and azoospermia are not the same. Aspermia has no semen. He doesn't get any ejaculate at all. Astenospermia has reduced sperm motility. I just want to look at this slide again. This is based on WHO parameters. WHO parameters have come under a lot of critical evaluation today. We will not go into that now because that's another big talk by itself. If you believe in WHO reference values, astenospermia has reduced sperm motility, asteroteratose reduced motility and more abnormal forms. Azoospermia is absence of sperm in the ejaculate. Aspermia is absence of ejaculate. Cryptozoospermia is hidden spermatozoa. Crypto is hidden, which means a fresh sample does not show spermatozoa, but the pellet, which is obtained by centrifugation, shows some spermatozoa. Hematospermia is blood in the ejaculate. Leucospermia is presence of more than 1 million leukocytes. Use a leuko screen to do that and confirm it. Necrospermia is all dead spermatozoa, which is very, very rare. I have not seen one true case of necrospermia. It's often total acinospermia, which people report as necrospermia. Normospermia is following all the WHO guidelines. A varying combination of these things can happen, but remember, oligoastenospermia is reduced concentration, reduced movement, and more abnormal forms. The current WHO definition has a lot of limitations. How do they derive at 39 and the semen volume is 1.5 and 15 beyond comprehension? But this is the value we are at the moment. We have to work around it. And again, we need to establish, all of you, when you start your own practice, you have to establish your own normal values in your region. This is what we attempted some time back, and we had a PhD student who worked on it. And we found that the normal values are much lower than what WHO published at that time, until WHO revised in 2010. This shows you how WHO reference values have changed drastically over a period of time. See that what happened in 1980 and what happened in 2010. The greatest change has been in morphology. It dropped from 80.5. How did they arrive at 80.5? Again, we are not clear. It has come down to now 4%. And 4% is the fifth percentile value. So you find the fifth percentile values have all markedly changed the last 30 years. The next revision of WHO manual may bring it down even further. And again, people are often told male infertility is equally contributory. The major cause of infertility today is not male or female, it's unexplained. People postpone age of marriage and age of childbearing. Remember, couple are maximally fertile in their 20s. Soon after they attain puberty and after menarche, after the first few years, woman starts ovulating and man reaches fertility. Both of them are fertile by 20. They delay having a child much later. They tend to become infertile. And this is what we found in our own data. We find majority of the patients have unexplained infertility. Male factor only contributes to 14%. And see what happened after the WHO manual. There's a drastic drop in oligozoospermia. What we have called as oligospermia is not any longer oligospermia. This is what's happening. Now again, as students of embryology, as practitioner embryology, you will be told that semen analysis is not a very reliable test, so we need to do sperm function tests. Personally, I feel this is a road to nowhere. In fact, we went through this process. We did a lot of sperm function tests in the past. It used to be sperm cervical mucus interaction test, HOS test, a lot of tests are there. The current fashion is DNA fragmentation test. We personally feel it's much ado about nothing. No professional body recommends DNA fragmentation test. Not ASRM, not ESHRI, not the European Urology Association. There is a wide assortment of specialized tests. All of them are not reliable as a test of spermatozoa function. Again, to reiterate Gardner, it's improbable that a single test would be useful. This is a recent paper which clearly indicates that in patients who are using a oocyte donor program, the oocytes are all coming from young women. Male men had both high DNA fragmentation and low DNA fragmentation. The fertilization pregnancy rate was the same, which means DNA fragmentation is not the cause of pregnancy, failure of implantation or whatever. I was invited to write an article on this. This was published by the journal. You can see the journal reference also, called Transnational Andrology and Urology. This is available free online. Remember, all the semen parameters are inherently variable. They're not fixed. They vary from time to time, and therefore you really cannot do anything by looking at one semen picture and deciding. And all determines is also the Spermatogenesis cells. So I would like to just say one important statement. Oligoactinomatogenesis is mostly untreatable. There are exceptions by and large, mostly untreatable. So what you should do is check up if there's any treatable cause, like infection, smoking. If there's no treatable cause, make the best of use of the available sperm and attempt a pregnancy by intrauterine insemination or intracytoplasmic sperm injection. Another area of this azoospermia and aspermia. Aspermia are not the same. Remember, aspermia is absence of ejaculate. Azoospermia is absence of sperm in the ejaculate. And again, a low volume semen may indicate if it's a complete collection. Very important, it can be an incomplete collection. Either it indicates vasal aplasia or ejaculate duct obstruction. Absence of fructose, again, in the semen sample, if it's a complete sample, may indicate vasal aplasia or ejaculate duct obstruction. By definition, azoospermia is absence of spermatozoa, the neat sample and a pelleted sample on more than 2 occasions of semen test, performed at least 2 weeks apart, is defined as azoospermia. It's not an uncommon condition. Azoospermia affects over 1% of general population, affects 15% of men presenting with infertility. This again figure varies from place to place. If it's a tertiary referral center, you may even find higher values. A proper examination is very, very important. Many ordinary laboratories just look at a semen sample under the microscope and report azoospermia. You need to do a proper centrifugation. And when you do that, you find many men reported as azoospermia turn out to be cryptozoospermic. And how do you differentiate? How do you diagnose a man with azoospermia? Either it could be an obstruction or non-obstruction. A simple test would be a clinical picture, normal testis, normal FSH, normal LH, normal testosterone. Most probably it's got a mechanical block. He has got a normal spermatogenesis and histology. A non-obstructive azoospermia is testicular failure, or I won't call it testicular failure, I would call it seminiferous tubular failure or dysfunction, or it could be due to hypogonadotrophic hypogonadism. How do you diagnose this men? Men with seminiferous tubular failure, high FSH. If there is also high LH, it indicates testicular failure. If both the components, Sertoli cells and Leydig cells, if there's no sperm production and Leydig cells are also non-functional, you'll find FSH and LH are elevated, the testosterone is low, that's testicular failure. If it's only azoospermia, otherwise it's only called as seminiferous tubular failure. These men have small testes. Remember, 80% of the testis volume is contributed by the seminiferous tubule. So seminiferous tubular failure or dysfunction will lead to raised FSH. If you do a pathology, histology, spermatogenesis is disrupted or absent or patchy. Men with hypogonadotrophic hypogonadism, these men often go to a general practitioner or to an endocrinologist, but they report to you they have low FSH, low LH, and the testis has not been stimulated at all, and therefore low testosterone. And unstimulated testis remain small, and they have poor secondary sexual characters or poor fertilization. You don't attempt a testis biopsy in this patient. The hormone picture indicates hypogonadotrophic hypogonadism. They require hormone therapy. That will be discussed later. Primarily, these men do not require, and doing a biopsy will do damage. This men with obstruction due to ejaculatory duct obstruction or vasoaplasia have normal FSH, normal testis, very low semen volume, and absent fructose. That's very crucial. Absent fructose in the semen sample and a very low semen volume of 0.2 ml, 0.3 ml. Normal FSH, normal testis indicates they have either of these two conditions. The way you differentiate between these two conditions is a clinical examination will show you absence of vas in the neck of the scrotum. Beyond that, man with ejaculatory duct obstruction may give you a history of painful sense of ejaculation, but nothing comes out because he is ejaculating on the closed ejaculatory duct. Men with vascular obstruction due to vasectomy, epididymal obstruction, or intertest obstruction do not show any clear picture at all. They all have normal FSH, normal size testis, normal semen volume, fructose is present. Remember, testis contributes only 5%. Therefore, there will be no change in semen volume. Endocrine picture again to give you obstructive azoospermia, everything, FSH is normal, LH is normal, testosterone is normal, and testis volume is normal. In non-obstructive azoospermia, due to pathology in the testis, if FSH is raised, if it's only sperm production is affected, LH is also raised if Leydig cells are affected, then testosterone also goes down, testis volume also goes down. In hypogonadotrophic hypogonadism, the problems in the hypothalamo-pituitary level, these people produce low FSH, low LH. Therefore, the low FSH and low LH in the serum. Low testosterone because testis is not stimulated. The testis has not grown further because of lack of stimulation, and they have small testis volume. This summarizes the workup of azoospermia. A man comes with azoospermia to an FSH. If the FSH, this low FSH and low LH indicates pre-testicular cause like hypothalamo-pituitary problem. If it's a high FSH, it indicates seminiferous tubular failure or testicular failure. Normal FSH, you may choose to do a biopsy, but remember there's no place for biopsy alone. Biopsy should always be accompanied by sperm retrieval and freezing. A standalone biopsy is rarely indicated today. If it indicates normal spermatogenesis as obstructive spermia, if it indicates testicular atrophy or maturation arrest, it indicates testicular failure. These are the references you can look up for further reading. And I think with this, I'll stop my talk. But there are some more questions on the chart, primarily for you to practice. Remember, the sex of the embryo is determined by the spermatozoa which enters the oocyte. For gonadal differentiation, a normal Y chromosome is important. The development of the genital tract, male genital tract develops first. In the absence of male genital tract development, female genital tract develops. Ambiguous genitalia, which again can present to the infertility clinic, is primarily because of androgen problem. Either it's too much androgen in the woman or too little androgen in the men. The sex of the baby is determined by the spermatozoa which enters the oocyte. Male external genitalia is determined by dihydrotestosterone, not estrogen, not testosterone. It's dihydrotestosterone. Gonadal differentiation requires, for testes requires SRY, SOX9, and other factors. For the ovaries, you require absence of Y chromosome, presence of both X chromosomes. Thank you very much.